advocate for them, create electronic medical records and clinic templates, and then counsel them, bring them together, and then put all this into perspective, which will align with Ghana's NCD programs or policies, which we have already. So what does this mean to us? It's a powerful tool. It's a powerful tool if you put your mind to it. It is with an aging population, the role of exercise is even more important. All doctors have an essential role to play to make every contact work. One patient comes to you, you put in the physical activity vital sign, which is what we've mentioned. Mention physical activity levels at every possible opportunity with your patients. Here in the NHS, it's not that simple. So don't think that here we have a rosy. No, it's not. It's not easy at all. It's on paper. We have loads of research. Nice guidelines have put it across. And yet it's not really being done properly. Our faculty is trying to promote that. Now, what they've done is they've removed the exercise medicine and put in moving medicine. That's what they are trying to. So moving medicine is what we are trying to encourage. So people understand, oh yeah, moving. So these things are for patients to understand, makes it easier for patients to interact with the clinicians so that you can improve all these issues. But if you say exercise is medicine or put in sports, then their mind gets diverted into elite sports. But this is for everybody. Okay, it's for everybody, which will help prevent diseases. Now, nobody is saying that you've got diabetes, don't take any medication at all, just do exercises. You'll be cured. Not quite. You need other factors, but include the physical activity. We haven't got to the stage where this man who bravely mentioned that no medicine in the future. We haven't got there yet. But on paper, you go to research, it's there that it can happen. Believe it or not, but it can happen. I'll run through briefly the burden of chronic diseases, which we all know, so I don't want to bore you with all these issues. I mean, here in England, there are over 15.4 million people living with chronic conditions. 50% of them have GP appointments, 65% of them outpatient appointments, and over 70% are in hospitals. That's a burden. And these are the key areas where exercise medicine will help. It's very important. These are the areas where exercise medicine and exercise prescription will definitely help. Okay, so now this issue about chronic diseases is going to rise within the next 12 to 15 years. Now, this is the Department of Health in 2010. So it's probably going up. We all know this, the issue about these diseases, which we know that exercise medicine will help and is embodied in a lot of epidemiological researches, which is all over the place. Overemphasis on pharmacological approach, yes, that's how we've been taught in medical school. I don't know you guys if you've had a whole 3-month session on exercise is medicine. Probably not, but it's very important that we know this is no brainer. We all know that the overemphasis on pharmacological approach is what we've been trained to do. But exercise is medicine is real. We have to understand that. Bits of statistics here for the UK. Over 40% are not active enough for good health, and it's still happening. It's now become the 4th biggest risk factor for non-communicable diseases, accounting for 300 million GP or patient consultations per annum. 75% of GPs discuss lifestyle often or always, but that's all it is. You come and say, oh, look, don't smoke, walk, do this. That is it. The patient leaves, no record. We can't go back and say, this advice has led to this patient's improved health. We don't know. So why isn't the message getting through? You see, this is the thing. We don't have the interest, even among health professionals. Forget about the government politicians, forget about medical authorities. We just don't have the interest in it. So the message will not go through. It's not going through patients. It's not going through patients, doctors, or health professionals. The only thing the patient will remember is going to the gym. This guy is super fit. So say, look, that's not for me. That's the thing. So we have to find a way of getting this into patients' care for patients to understand that. Same way we encourage people to take their own blood pressures these days. Now, in Ghana, this is what we have. Okay. Currently, at least as far back as up to 2020, it's going up. The physical activity, inactivity trend is going up. We are developing. Okay. Now, according to in Ghana, this is I think 2023 or 24 analysis, 2023, that 40 to 50, 65% of all deaths are cardiovascular or diabetes or related issues. In 2023 analysis, there was a report in Ghana that 65% of deaths in Ghana are related to NCDs. And it's true. Cross that and you go into the risk factors: tobacco use, harmful alcohol use, physical inactivity, overweight. They are rising in almost all countries, including West Africans or Africa. We have to remember it's happening. It's happening in our own eyes. We can see it. Okay, you can only see it if you have that mentality of exercise is medicine. Okay, so now, one of the things that's happening is increasing urbanization, changing occupations, transport patterns, and increasing sedentary time and inactivity. You sit in traffic 3 hours in the morning, you're going home, you're so tired, stressed after work, 3 hours. You go home, issues at home, you sit watching TV, probably another 3 hours. You calculate that, say Monday to Friday, I said it before, calculate that throughout the year, and you understand why people get these kind of diseases. So the policy content is what I was talking about. Now, who did the report for Ghana, which further emphasizes the urgent need to address lifestyle issues? Ghana is developing very fast. In fact, there are some places in Ghana, you go there, you probably think you are in the US or UK or something like that. Only cars are around. You don't see people walking about. You see, these are lifestyle issues. That's what we've chosen to live by, and that is part of development. So the epidemiology of disease in Ghana has shifted to NCDs, and physical inactivity is a central modifiable driver, which we can do something about. So this is a clinical and public health space where exercise medicine can get in, but the space is there, but nobody is pushing that into that space. So we are all suffering as a result. I always say this: there are 5 things that control our health, whether you live, wherever you live around the world. The first one, there's nothing we can do. Very difficult. Only God can do something about it. It's our age. We are all growing older. As you grow older, our gene component degenerates, so we'll be at risk of all these illness. Nothing you can do. It may be linked, it can be linked, or it may be linked with genetic factors. If you have a genetic factor for disease in your family, there's nothing you can do. But there are 4 things, the rest of the 4 we can do something about: smoking, alcohol, diet, weight, and exercise. So these are the things that exercise as medicine wants to get into to improve people's health, but we are not allowing it to happen. So we need somebody who understands exercise as medicine, who will push it into that public health space I'm talking about. The space is there. If you have exercise medicine mentality, you go to Ghana, you see the space, but nobody is putting that, is fitting exercise medicine to that space. Now, this I won't go into. It's been mentioned many times. You go on Google, it's all there. These are the principles which the American College of Sports Medicine developed, and it's still pretty much the same. There've been variations of it, but pretty much the same. Now, exercise medicine has become so problematic that the British Journal of Sports Medicine dedicated a whole journal to it. Very interesting. If you get this, read through it. Very, very interesting. It goes through physiotherapy, health professionals, clinical care, and so on. People have put in a lot of research into it. And it shows that the gap is there even here in the UK and other Western countries. Who will take the exercise medicine and try and fit it into that public health space, which currently is empty? So this is July. Before that, in March, they brought the same issue, miracle drug, the need for physical activity prescription, which is what I'll show you in a second. Is there? Nobody is doing it. People are dying purely because of this. Now, if somebody dies and we don't know about the death of that person and autopsies are done, there's always a component of physical inactivity which has caused the death. Not alone, but it's linked with whatever is happening. But nobody puts that in the reports. You see, so our minds are tuned towards the way we've been trained, and nobody is thinking about exercise medicine. But it's very important. It's a miracle drug. But who are you going to go to the pharmaceutical companies and convince them? It will never happen. These guys are looking for money. They are money-minded. We all know that. We are human beings. We know that. Okay, so it's there. It's real there. The space is there. Remember, there's public health space for exercise medicine to get in. Nobody is doing that. I know it means healthcare professionals who need it, admin support, political support, medical authority support, and your own interests, you know. And a lot of people are doing exercise medicine clinics here for nothing, no pay, but it's because they have the interest in it. Okay, so imagine if somebody in public health says, hey, we have to develop a hub and help our people. You will see the instant connection to have, or put it across in a newspaper or a major news item, then you understand. Okay, but we are really not doing that. So the space is still there to be filled. How do we write exercise prescriptions? Same thing. I'll run through this very briefly. Now, it's the same thing that we do for prescriptions. How many minutes do I have? Sorry, Gamele. Okay, I've got 15 minutes. Is that correct?
Yeah, 15 minutes. Yeah.
Okay, I'll run through these ones very quickly. So it's the same as medication prescription. Difference is, instead of exercise, instead of medicine, use exercise. Strength, frequency, precautions, you put all this down. And refills, you come back for your metformin every 3 months or whatever it is. So it's the same kind of prescription pad which we use. I've developed mine from this guy, Prof. Jonas, who I met in America a few years ago. Now, he developed this, and I've used that. It's very simple. I'll show you mine, which I'm sure I have at another lecture. If you are doing exercise prescription, you always have to add motivation, motivational interviewing, communication style, so that the patient takes it on board. I will do it every day, 5 days of the week. I will give you the record of what I'm doing. 3 months, I will see the doctor. The doctor re-examines, re-evaluate to see the impact on my health. And it's been proven, all this has been proven, and it's part of the NICE guidelines, which has been updated, but it's the same as we speak. Now, this is the way to do it. It's simplified, but you have to be trained for this. You assess the patient's ability to do the exercise. You advise. Both of you, you and the patient, agree to it. Then you assist the patient to do it and arrange the patient to do it. Now, the assist and arrange, you need admin help to do that. All this, when you get to the assist side, that's where you write the written prescription. So that is the key thing. But here, you need admin help. You can't do it on your own. It's very difficult. You have so many other things to do. You would probably not be able to do it, but you need admin help to do that. And the admin help, the person who helps you with that, should also have the mentality of exercise is medicine in the mind. Okay, it's very important. Now, this is what I've done. This is mine, which I use here. Okay, the same thing. I've put these walking. These are the common ones which our patients do. And I join them for 30 minutes. Some of our staff and myself, we are developing a t-shirt so that we can be more visible. We do 20 to 30 hours walk. And we've incorporated.
Dr. Anand,
Yep.
could you
Yeah.
put it in a full slide? The writings are very tiny.
The writing, I don't know. Okay, hold on. How do I do that then? I'm not sure, I mean,
do you
you
see
can,
us maybe I'm not sure.
that is, and so how am I going to do that here? I'm not sure. Maybe, I mean, if anyone wants a slide, they can have it. Then they can see it properly,
sure.
I think. Yeah. Because you got the slides, isn't it?
Yeah, I have.
Okay. So I think we can do it that way. So this is how I've developed it. And this is the prescription part itself. This is what I'll sign and the patient signs. Okay. And this is the activities. Whatever activity the patient wants, he does it and then he signs here. I tell the patients, if you don't do it, I will know, because if they don't come after 3 months or they haven't done it, you will know by simple tests on patients' weights and so on, because you will have a background check first before we do that. So it's very valuable. So I incorporate the same thing, which we call FIT principle, which is the key thing in exercise medicine. Okay, and the exercise prescription part. You have to include all this, similar to a prescription. 5 days a week, mild exercise, either normal walking, moderate, brisk walking, or vigorous walking. You can do all that, which is equivalent of jogging. You can do that. 20 minutes, 2 minutes, it doesn't matter. You go 2 minutes, you can continue doing that 2 minutes from different times during the day and then make up your 20 minutes. So you can accumulate 30 minutes in a day. This lady is using the stairs. He's done 10 minutes, 5 minutes, whatever it is, and then you accumulate it during the day. But you have to be making sure you put records in and then give it to your doctor, who will help you with further assessments and evaluation. Type, you can use aerobic activity or muscle strengthening. Simple. You can even take a Coke and then use that, a filled up Coke. Use that. You might think this is nothing, but it's very important. Okay, very important. Dumbbells, fair enough if you have them. But yeah, I mean, you can do that as well. So upon all this issue, why are we still struggling with this issue about exercise medicine? To be honest with you, for me, one of the biggest issues is, look, my colleagues, they don't have any interest in it. They simply don't care. That's my view. Others will say, well, time constraints. Why do you have to sit down and talk to a patient 10 minutes about physical activity? That's the last thing on my mind. Sometimes they are afraid to offend patients, to lose weight. The way they say it is another issue. Lack of services locally. True, that depends on the council and the government. True. And reliability of services around the where you live. Weather is important. And the GP surgery, the admin at GP said, oh, we don't have the capacity for these things. It doesn't make anything to that. We don't get money. We need money, who pay for our help for patients who exercise. Nobody will pay. The public health don't care about us. We don't have time. You see. And other GP will say, we need training. Who's going to the training? There's nobody. So these are some of the things. But this bit, the training side of it, is what our faculty here in the UK is trying to resolve. That is coming. And there's a way of doing that. And if the establishment of sports and exercise medicine and rehabilitation medicine have the interest, I can point you towards the way to do it. Okay, so these are kind of things that we are looking at, training for brief interventional awareness, training, knowledge and behavioral change, workshop, conferences, online support, and so on. These are things that we can use to do. But this is what I've done here, managed to do, not successfully all the time, because I worked with a group of people called UK Active. You start with level 1 and go to level 3. I was just going to level 2, they cut the funding. So I'm still around level 1. I'm waiting for the funding to come back, and then I'll incorporate what I've done into that. That's what we do. We use peer support, we have incentives, we go to schools. Only 2 days ago, I went to a school to encourage the children and the teachers about exercise medicine with nutrition, and it's gone down well with them. Now I'm still working with UK Active, but because their budget has been cut, we don't have any way forward yet. But I know that it will come pretty soon. Now, one thing the government have poured money into is called social prescribing in the UK, which I mentioned earlier. Is they will show you how to garden, gym work, and so on, all based on the principles of the FIT principle, which I showed you earlier. So that is used for gardening. Say you garden, you're gardening for 20 minutes. You do it for 1 hour or so. We have a way of dividing those times, and we incorporate it into our data, and then we follow it up with you. Anything that has physical activity in it, anything, working groups, whatever, we have to get data from it. And it's quite easy to get the data using the principles which I've mentioned earlier. So what is the future? This is what all we need. It sounds simple, but not easy to do. Luckily, we have the sports and exercise rehabilitation medicine, who the fellows have known this, they have interest in it. The ones who will develop the interest in it is who will take over from me or from other hubs will be very important. Because in Ghana, sports and exercise medicine is always football, athletics, those kind of things. That's what occupies their mind. But it's a huge area which will improve people's health. That is untouched, which is exercise medicine. That's what we're talking about. But there's hope. I know the family medicine, sports and exercise rehabilitation medicine know this, and they are taking it on board. Okay, so to conclude, Ghana and Africa, West Africa, we are in the midst of this burden of disease. It's ongoing. People die suddenly. People struggle to have struggle with their health. By the time they get into hospital, they pass away. There's so many things, but you see, nobody actually looks at physical activity as part of what is happening to a lot of our patients or our people. We only look at hypertension, diabetes, asthma, those kind of things, but we don't actually look at the effect of how physical activity will help these patients. It's out of the window. Nobody thinks about it. But the good thing about Ghana is that we have strong NCD, non-communicable disease policies, and research. A lot of research has been put in Ghana. It will amaze you. Some of the information I've got here for Ghana are from those research done by Ghanaians, which are all over in international journals. So, but we need to turn that policy and evidence into our work, into asking, which I mentioned earlier, advising, prescribing, and referring for exercise in every relevant consultation. Can we do that? Yes, I think we can. We are in the right path. So the take-home message is this: exercise is no luxury or hobby. It is powerful, it is cost-effective medicine, and all clinicians and health leaders, we must treat physical activity like a vital sign. Prescribe it with the same seriousness as drugs, and build the systems and partnerships, which is currently not there. And that is the public health space I'm talking about, which is not there. And make exercise as medicine a lived reality for our patients and communities. So remember, we have a public health space. It's not being filled with exercise as medicine. We just need people. We need some of you or all of you to get into it. Lobby the politicians, lobby the medical authorities to have this system in place. If they don't know about it, use these slides and then try and convince them. They will understand. Okay, so this is the information I've got a lot of this information from, and this is the reference. I know it's very little, but a lot of these are done in Ghana. A lot of these references have been done by Boache, we have Ajiman, K. Abudulai, K. Very important. I don't know why this important literature is there, but nobody's taking it and then putting it into practice, which is what literature is supposed to eventually end up to improve the well-being of our patients. Thank you all very much for trying to understand this vague, invincible exercises medicine concept. And I hope I've done enough to convince all of you that it's a very important part of our well-being. Thank you.
Thank you very much, Dr. Anand. That was a very insightful presentation. Do we have any questions for Dr. Anand? I can take a couple whilst we work on the next speaker joining us. So if you have a question, you can just put it in the chat. I will read it out and then can have an answer.
And there's somebody's hand up, I think.
Okay, so Alex Minka, he says, I'm an exercise enthusiast and I encourage my patients to exercise, but the one problem they complain about is the spaces in the communities.
Yeah.
My appeal to the authorities that manage our spaces they should incorporate they should incorporate that into the parks to help encourage exercise. Also, that's more of a contribution. Thank you very much, Alex.
Thank you.
Hello.
There's Philip also on it.
Hello.
Yeah, hello.
Sorry, my buttons are not working. I wanted to raise up my hand, but
Okay, we can hear you, so maybe you can just ask your question.
all right. Thank you, Dr. Anand. This Dr. Sida, also a family physician. You mentioned one way of encouraging our patients is to let them see their numbers. I was wondering if you could give a brief idea of what that is. Is it that they should check their weight every time they come back to the hospital, or they should check their pressure? That in terms of what they can see as time goes on, so that they are more encouraged when they come to the hospital, so that they can continue on doing their physical exercise. Thank you.
Yeah,
And a great thank you.
yeah, you're welcome. Yeah, Doc, I mean, yes, this is the exercise prescription that needs to be developed. You know, you see, it's easy to develop blood pressure, weight, pulse, and so on, where you can follow up. But the physical activity side is not part of this lecture. Otherwise, I will show you how the data works. It's very simple, but you have to follow up the patient and record the data, you see. So when I do mine after every 3 months, I start with the physical activity, vital sign, and then follow up. After 3 months, I do the same again. 3 to 6 months, I actually repeat a blood test to see, especially if the patient has developed hypercholesterolemia, for instance, and it's known to reduce that with these exercises. So this will be outside the realm of this, but if you make contact with me, I'll show you how it's done, and so that you can get that information, data, and show it to the patient that, look, since you've been doing it, this is what has happened. One of my patients, I showed him, this is a blood test. That's your cholesterol before. You haven't taken cholesterol, the tablets, but the physical activity has helped you. He was astounded. You see, these are some of the things that but you have to be careful. You have to follow up the patient, make sure there are no other risk factors that can harm the patient. But it's there. I mean, if you are interested in it, make contact with me through Gamele, and I will show you how it's done. So you are right. That's the key thing that will encourage patients to exercise.
Thank you, sir.
You're welcome. Okay.
I think
Yeah,
Philip has his hand.
Gamele, there's Philip.
Yeah.
Philip was raised his hand, I think.
Co-host, can you unmute him?
Philip.
I have.
Okay.
Okay.
Philip, the
Hello.
floor is yours.
Yeah,
Yeah,
thank
hi.
you. Thank you for the presentation, Dr. Anne. Yes,
Hello,
I
Philip.
think, can you hear me?
Yes,
Yes.
we can.
Yes, I think one area that I need to just say is this. As a sports scientist, I think there is need to do a partnership with the GES and then the university. I'm saying this from experience. In my university, there is a course that is general course that they always take. That is Introduction to Exercise Science and Nutrition and Applied Exercise Science and Nutrition. And it has been of a great, immense contribution to the student. I would say last year, 2 of my students were having back pain, including spinal disorder. But based on the prescription and the dosage, and then the process of exercise, they were able to get over it. Not this semester, another person was suffering from menstrual cycle. But after raising up the leg, which is the simplest form for weeks, there was a change and the end condition changed. So I think in order to promote exercise is medicine, I think there is need to do a collaboration university in order to incorporate it as an general course that will allow them to go through the process, and also partnership with experts in sports science. This will allow to draw a modus and a program that will be different from just 1 month, a week politician walk out, and that is the end. So and then with this literature, it can be presented so that it can serve as a policy guide that will help exercises in medicine in Ghana and in West Africa. Thank you.
Yeah, thank you, Philip.
You were breaking up a bit, so
Yeah.
we didn't get the entire picture, but I guess we got the overview.
Yeah, I think we've got it. Yeah, I've got it. Yeah. Yeah, thanks, Philip. This is exactly what it is. The collaboration is very, you see, the collaboration works very well if we have a hub. A hub, what I mean is a group of people, identifiable group of people who anybody can, the government, politicians, medical authorities, and so on, can come in and say, look, we want to do this. We have exercise science here. We have this here. We want to come in, collaborate, and then help our population. You see, so I said that in the slides. We need the collaboration. So it's very important. I mean, Phillips University, for instance, it's a key place where we can collaborate. So thank you very much, Philip.
All right. I don't think we have any other questions. Dr. Annan, okay. We would like to thank you very much once more for agreeing to do this, for these insightful presentations. I'll be reaching out to you. A couple of people want your contact, so I'll be sharing mine so they can reach out to me out of here, and then I can put them in touch with you.
All right. No problem. Thank you all. Hopefully, I'll meet some of you very soon next year.
Yes, fingers crossed.
Yes.
All right. Thank you.
Thank you all. Have a good evening.
Good evening.
Bye-bye.
Hello, everybody.
Hi.
Good evening. This is Conrad Buckle speaking.
Good evening.
Hello, Gameli.
Hi. How are you doing?
I'm fine, thank you.
All right. Thank you very much for joining us. Do you have some slides to share?
Yes, I do.
Okay.
If you want to finish with your introduction, I've got a little poll that I may also do right at the beginning. So if you
Right. So our next speaker is Dr. Conrad Kwesi Bako. He's an emergency physician. He will be giving us a talk on concussion management in sports. Dr. Conrad is a fellow of the Ghana College of Physicians and Surgeons. He's a fellow of the Royal College of Physicians, Edinburgh and Glasgow. He is Ghanaian, lives in the UK. And yes, he's well versed in the topic. So, Dr. Conrad, your audience.
Thank you very much. I thought I heard you say, I'm going to be talking about concoctions because my cooking isn't that bad. Anyway, so what I'm going to do is I have an emergency medicine background. I've worked with Dr. Annan in the sports medicine sphere with regards to the emergency medicine aspects. And I've been asked by your faculty to present on management of concussions with specific respect to the sports medicine team. I'm going to share a presentation now. I got notice of this just a little while ago. I've tried to make the effort to get as much evidence by way of presenting you with something which you can follow up on the references. So when I finish, I will share with Gameli or Abna my slides. So I have a short, simple version and an extensive version. So I'll be going over the overview today. If we have time at the end, we might go through a couple of concussion incident scenarios. And then hopefully at the end of it all, you'll be happy that you have refreshed your memory on the subject. And you've refreshed your memory on the subject and perhaps learned one or two new things. And I may also learn one or two things from you. Okay, let's see what we've got here. I need to get this out of the way. Yeah, okay. Okay, okay. Right. Can you all see my screen?
Yes.
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 Okay. Now, is there Mr. Maxwell on the call?
Maxwell, Amo.
Yes, Maxwell is on the call.
Okay. So, just to get a feel of where all of us are, I'm going to ask Maxwell to just have you take a couple of minutes. There's about 10 questions, maybe 9 or 10. Most of them are yes, no. And I just want you to just indicate yes or no regarding any possible concussion patient or incident you may have had recently. So, Maxwell, are you able to run the poll now? I see there are 200 and something people in attendance. So, obviously, we can't all give our names and where we are from. So, if you can just
Should I launch it?
yes, if you can launch it now, please.
Okay.
So the first question is, what role do you serve on a sports medicine team? Now, I know this is maybe a general audience. So, Maxwell, are they able to see all the? Okay, can you all see the answers? So you're either a team physician, a nurse or paramedic, sports psychologist, nutritionist, coach or trainer, medical administrator, EMT, researcher, academic, or none. So I'll give a few seconds for that, please. So as far as I can tell, there's 200 and something of you. If as many of you if we can get to at least 100 of you responding, that would be fantastic. So just say what your role is. There are 10 very, very short questions. So we'll finish in a minute. Okay. All right. So I'm going to question number 2. Yeah, if you responded none of the above, then you thank you very much. Your participation ends here. For number 3, have you recently been involved in managing a case of concussion in sports? So just say yes or no. Whether it was, whether you were playing and there was somebody who was injured or you were injured, whether you were in the emergency department, whether you were a physician and somebody came to your clinic. Then number 4, if you have been involved, was it an adult, a child, or an elderly person? Then the sex of the patient. We know predominantly boys will be boys, men will be men. Predominantly, the majority are men, but there may be some females who have had concussion that you've treated. Number 6 is, Maxwell, I gave, okay. Anyway, I wanted a selection of sports, but yeah, if you can just, okay. For number 6, we might have to do that verbally. Then the mechanism of injury: direct contact, a fall, overuse, repetitive strain, hyperextension, blow to the head, non-contact. Then number 8, was the diagnosis made immediately on scene? So where the incident happened, or was it delayed? Did somebody come to your clinic 2 days later, 2 weeks later, or a few hours later, or were you on scene and therefore able to make the diagnosis or work at the time? Then if delayed, there's some options about why there was a delay, which include the symptoms were subtle, initial symptoms were attributed to others, symptoms were underreported, inadequate awareness of concussion recognition, and no diagnostic. And then number 10, no. Number 11 is, were you on scene at the time of the injury? So yes or no, simple. Okay, so I'm going to give just one more minute and then I'll start my presentation. Maxwell, are you able to collect the information to date up to now?
Yes, if we end the poll.
Okay, all right. I'm going to end the poll in 10 seconds. 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, I'm going to end the poll now. This is just a little taster. So I'm going to end the poll now. And Maxwell, if you can collect the information. Actually, I can share the result. Let's see what happened. I will share the results now. Okay. Okay, so according to those who responded, we've got 44% are doctors. We've got a small number nurse, emergency, EMT. Then we have about 30% have been involved in managing. We have involvement with child and adult, but no elderly concussions. The majority of patients were male. The mechanism of injury, direct contact or fall. The diagnosis was immediate, well, about 50-50, immediate and delayed. And then a lot of the delays are subtle or thought to be other causes. And finally, most of these were not on the scene or solo. They were only by themselves. Okay. All right, so I'm going to come off this now. So that's just a little background. Some of you just keep that in mind as we go through. So okay. Sorry about that. You've got to. Do apologize. This is okay. I've got a bit of a glitch with the present mode. I do apologize for that. I didn't have time to transfer this into a PowerPoint mode, so okay, let's try this again. Working. Okay, let's exit this. And okay. Right. So the sorry, I do apologize for the cluttering of the page. So what we're going to do, we're going to try and understand the pathophysiology and clinical presentation of sport-related concussion, recognize the role of the multidisciplinary sports team, apply standardized tools such as the SCAT Sports Concussion Assessment Tool version 6. There's the framework of the 11 R's, which we'll talk about, and then look at graduated return to play, and for that matter, return to learn protocols. And then there are legal, ethical, and communication issues to consider. Now, why does concussion management matter? it's an invisible injury crisis because a lot of people have what we call minor head injuries. And it can be something as simple as knocking your head on a cupboard when you're taking something out, accidentally running into a door, something falling off a balcony onto your head, or in contact sports like rugby, American football, football or soccer in North America, actual contact sports where sometimes the aim is actually to hit the head, as in boxing. But for the invisible injuries, those are things that people in normal everyday life may have, and a lot of them may never present or may present in a delayed manner to their primary care physician or a frontline healthcare facility. So those with full sports medicine teams on site at football grounds or basketball courts or badminton or during the Olympics or during the World Cup or gymnastics, they have the best chance of early diagnosis and interventions. And also with an organized team, you have the best chance for planning ahead in order to anticipate the prevention of adverse effects of concussions. So they tend to be difficult to detect. There's no mark because the skull is quite hard, and all you'll see is maybe a contusion, a bruise, the occasional scalp or face laceration. And athletes, especially at the professional level, tend to feel that they have to play because of there's money involved, or they don't want to lose their place on the team. Long term, you have things like depression associated with it, cognitive decline, early dementia is one CT, and chronic traumatic encephalopathy CT, and then sometimes you have other serious medical conditions which may be associated. Now, in the last couple of decades, there's been a shift in it used to be the sexy thing was traumatic brain injury, which is car accidents, penetrating injuries, the things you can see. But more and more, it's been discovered that these subtle injuries can progress to longer-term damage if they are not detected early and precautions taken to prevent the return of people to sports and activities where there is the chance of repeat injury to the head, or indeed minimize some of the longer-term neurological and cognitive effects. So the current aim of the profession or professions related to sports are to prioritize brain health over winning. So if a star player gets injured, usually there is the team is concerned, and as is the player, that if it happens 10 minutes to the end of the game, there's a fear that if they take their star player off, they may lose the game or they need the star player or a particular player at a particular position in order to increase their chances of winning or to reinforce the fact that they are leading. And that is what used to happen. But now the priority is the health of the brain over winning. And so the sports medicine team members, physicians, physios, and allied health professionals are often in a dilemma because they have a fear that they could lose their job if the manager or the team owner feels that they lost a match or an important World Cup or otherwise because of the priority of the brain health over winning. I did a little bit of a search of the historical look at I'll send you, I'll make sure you all get copies of these, which are all referenced, and there's a list of references at the end of it. So it goes all the way back to ancient Greek times. Hippocrates is said to have documented the earliest signs of a concussion. In the 20s to 50s, there's mention of, you may have heard of the term punch drunk in boxers. There's a term dementia pugilistica, which again applicable to boxers. And then there's a link established to chronic traumatic encephalopathy in the late 40s, early 50s. In 1992, WHO had a post-concussion criteria for the ICD-10. And then the sideline evaluation was formally conceptualized in 1997. Now, in the early 2000s, there were conferences around sports medicine, which looked at discussing and having concussion as one of the topics or the main theme of the topics. And then there was also investigation into young people and the traumatic brain injuries affecting young people. In the 2010s, meetings in Zurich recommended a multidisciplinary approach. So we are talking about a sports medicine team. So the multidisciplinary approach was discussed, a little over 10, 15 years ago. And then the protocols were put in place for trainers. The trainers, athletic trainers, are those who are attached to a team and who deal with things like massaging sore muscles, dealing with sprains, getting people back to normal after an injury. And the 3 R's framework was introduced. We'll talk about it in a minute, in Berlin. In the 2020s, this is very important to note. The references will be provided. The 6th International Conference, Amsterdam, formally discussed and agreed a general global consensus on, the 11 R's and how to manage concussion. And then there were new sports concussion assessment tools. The latest version is a version 6. Dr. Anand might correct me on that. Then in 2024, there's a biopsychosocial model, which looks at not just the brain injury, but the biological effects of the injury and then the social effects. So a holistic view to looking at concussion. FIFA has adopted a campaign, Suspect and Protect. So once there's a suspicion that something that happens on the field of play or is related to some sporting activity may have or could possibly have resulted in concussion, the individual needs to be protected. And if that means pulling them off, they get pulled off. And if it means not allowing them to go back for the agreed number of days or weeks, then so be it. So there's an ethos that is saying that concussion is more than just a bump on the head. It used to be that unless somebody had their brain pouring out or, bleeding from, a huge cut, it was just thought, oh, it's nothing. I mean, it's just a little bump, especially when there was a little contusion, and then they'd say, oh, put some ice on it, and that would be the end of it. But obviously, as I showed you, the historical trend, for decades and if not centuries, it's been realized that what might appear to be a minor blow to the head can sometimes have long-lasting, effects that last for days, weeks, sometimes much longer. So we have some definitions. The medical definitions include traumatic brain injury, and the traumatic brain injury is caused by biomechanical forces. So the head is formed of a skull with the soft brain inside, and the brain moves around when it's jolted. So there's the biomechanical physical force, which can physically shake the brain and cause damage in that way. There can also be bleeding. But then the neurons, the axons, the neurons can also be affected, stretched, damaged, and then that can lead to cognitive and functional injury of the brain. Standard imaging for concussions is often normal. Mechanisms of injury include acceleration, deceleration. So typical whiplash type injuries, or in the sporting environment, clash of heads, or a ball hitting a head when they're not expecting it, as opposed to a football player who is planning to head a ball. So a football player who's not aware and gets hit, or a spectator in the stands who gets hit with a shot moving at 50 miles an hour, is likely to have a concussion. So direct head, face, neck blows, as in boxing as a sport, or in the public sphere, a fight at the pub or at the chop bar, or at a family gathering. We're coming to Christmas, so there may be a few of these family gathering or public blows. So the clinical features. Now, if there is a rapid onset of neurological impairment, the brain sometimes shuts down. So you have a blackout or a temporary unconscious state, or in serious cases, obviously, they may go into a coma. The effects of this are usually short-lived. So somebody might say, I saw stars, or I felt a bit, I was dazed. And that may last a few minutes, or hours, or it may go on for a few days. Or sometimes there's not much on the day. They may complete the activity that they were participating in, but then when they come off, they go home or they go back to school the next day. 2 days later, they're feeling worse and worse, and that can take days, sometimes weeks. Some common myths are that there's always loss of consciousness. That's not the case. Somewhere 10% or less, may have a loss of consciousness, but the majority may just feel dazed, or they may not actually feel much at the time, but feel the effects after hours or days. There are many athletes that have serious brain injury, but are actually conscious. So the myth that if it's only when you are knocked out unconscious that you have a serious brain injury is not the case. Symptoms are not always immediate, and it's not just direct head impacts. As I said, ball to head.
Hello. Long time no see. How are you?
Hello? Oh, sorry.
Okay.
Somebody's unmuted themselves. Okay. So the key point here is that
Okay.
any suspected concussion requires immediate removal from play and medical assessment. And so when in doubt, sit them out. So that's a common saying these days. When in doubt, sit them out. And that's a reminder to sports medicine team members to keep in mind. Now, these are some of the phases of managing a patient. So the 11 R's are included in this diagram. So you've got those to do with immediate care, recovery and prevention, and then to recognize. At the core of how you manage concussion and concussion incidents is recognizing the signs of concussion. So that's 1R, one of the first ones. Then the immediate care, which is the next level care or process of managing concussion, is to remove the person from the activity. So if they're playing football, take them off the pitch. If they're playing rugby, take them off the field. If they're playing basketball, take them off the court. Remove them from the scene. Reevaluate. So as soon as possible, reassess them, and then make sure they rest. And then obviously refer as soon as possible to an appropriately trained person. So you would refer somebody like that to my colleague, Dr. Annan, as a sports medicine specialist to look at it. And then recovery and prevention. The individual needs to be rehabilitated, both physically, mentally, and indeed socially. You want to manage their recovery. If they are in anything professional or high-level organized sports, they have to return to sport in stages. And you will need to, as the days and weeks goes by, there has to be reassessment as to whether they should or should not return back to their activity or their sport. And then you need to look out for and continue monitoring for residual effects and assess the risk of future injuries, whether they should even continue in that sport or in that activity. some of the statistics or some of the sports with high prevalence of concussion, ice hockey. Now, some of you may not have seen, but those of you who've watched ice hockey during the Olympics or on TV, it seems, violence, people getting into fights is part of the game. And right from the time they are children, they will just knock off their helmets and start punching away. They also, obviously, they're on ice. Sometimes they slip or they fall and they slide on the ice. They can hit their heads. They can hit their heads on the sideboards of the ice hockey rink. Rugby, you all know rugby. American football. Now, isn't it interesting that women's football seems to have higher concussion rates than boxing? That's interesting. And then you've got things like cricket, where the ball, obviously moving at high speed, can cause a lot of damage. These are some numbers. Once again, I'll share all of this with you, so there's no need to memorize the numbers, only to say that they are large numbers. So, 1.6 getting to 2 million annual concussions. This is UK, from the Royal College of Surgeons. 15% of these are young athletes. Women are 3 times more likely to sustain concussions. I suppose men are 50-50. Either they don't have much, or they don't complain about much, or they get a serious injury. So then or men may just not admit to having signs of concussion. Also, men are more likely to persevere and hide their symptoms. I think Dr. Anna will probably vouch for me with that. There's also a lot of underreporting, 42% underreporting. So the brain, what happens during a concussion? The brain floats in fluid. During rapid movement, the brain hits the skull, and there are shearing forces, and different parts of the brain move at different rates. And it's the neural connections which cause the problem. So you've got the moment of impact. The brain under the site of the impact may be damaged, but then you also have a contra-coup effect, which means as the brain is thrown to the opposite side, that aspect, the other side of the brain, hits the solid skull, and so you have damage there too. And in between those two sites, the site of the direct impact and the contra-coup opposite side, all the axons there are subject to different forces which may affect their function. The frontal and temporal lobes are particularly vulnerable, and they control executive function and memory. At the cellular level, there may be disruption of the cell membranes. The brain may be damaged and be less able to cope with, producing energy for itself, which may affect the long-term effects. There may be reduced blood flow. And so the other thing to note, and the reason why, when in doubt, sit them out, there's a vulnerable period where soon after, or in the period of time after a concussion, an individual is prone to more another concussion or more serious brain injury. So we got a cascade effect of an initial impact, then the cellular effects. Because the cells are not working normally, there's less energy for the brain to function normally. There's reduced blood flow, and then that affects the vulnerability of the brain. And so an initial recovery phase of normally, a week, 7 to 10 days is what is usually allowed for, and adolescents or young people may take longer. So this explains why all the regulatory bodies in all major sports have a minimum of 2 weeks, sometimes 2 to 4 weeks or longer, depending on the category of concussion. Because during that 1, 2, 3 weeks, if they have another injury, it's more likely to lead to longer term adverse effects. So what do you look for on the pitch? Some of the physical signs headache, nausea, dizziness, confusion for cognitive effects, memory problems, emotional problems like irritability, personality changes, sleep disturbance. And then things that medical staff should look for. Now, the people who are most likely to know what to look for are those who spend the most time with players. I'm talking about organized sports, professional or amateur. So your trainer who's there every day and working with different players, or the coaches who coach the offensive side of the team, the defense, strength coaches, the dietitians, they interact with the players more than probably the main manager or coach of the whole team. So in the same way that we rely on family to tell us about signs of dementia, memory loss, confusion in elderly patients, the team's medical and coaching staff are those who are more likely to recognize that the right center half is been a bit confused or is acting or behaving a bit strange since the last match, or the guy who was playing hockey and was hit in the head 2 days ago, it doesn't seem to be quite right when you ask him about things that he should remember. So the whole team works together in that sense. Some of the immediate red flags are loss of consciousness, lying motionlessness, unresponsive, seizures. Some behavioral changes are being slow to answer, blank vacant stares, confusion about things that have happened in that game. If you ask somebody, who scored the last goal, and they have no recollection, even though they may be the ones who scored the goal. Physical observations may include unsteadiness of gait, poor balance, vomiting, and then obviously clutching the head, as a sign of severe headache. During the first moments after the impact, there's a little image there of people running onto the pitch. And some of these things are things that the team, the sports team need to sometimes practice. How many people go on, which people carry the stretcher, which people do the assessment of the airway, the breathing, the circulation, somebody does the assessment of the Glasgow coma score, or the SCAT-6, the sports concussion assessment tool, all these things. So everybody gets a task, so that, like a Formula One team that is changing tires of a Formula One car, you go in, everybody does their bit, and the idea is a quick decision has to be made as to take them off the pitch or whether they're okay. And in the current climate, in the majority of cases, the player will be taken off because you cannot do the full proper assessment, and you'll be taking valuable time from the game. So the referees and the teams will usually allow for a short period, and then either they are 100% okay to stay on, or if there's any doubt, sit them out. Now, when they're taken off, if the game is still in progress, somebody has to be assigned to them. They don't just sit on the bench with nothing happening, nobody observing. They are not left alone. Instructions must be given to whoever is supposed to watch them on what to do. And obviously, at the earliest of opportunity, either they get transferred to a health facility immediately, or if it is borderline, they get monitored during the rest of the game, after the game, and then in the 24 to 48 hours afterwards, specific monitoring is done. So who are those involved with the team? The team physicians or doctors, the trainers who help with the sideline assessment and day-to-day, minor sprains, aches, physiotherapists for rehabilitation, neuropsychologists. So the neuropsychologists look at the external manifestation of reduced brain function. So they administer the different tests, and actually at the professional level, players have baseline cognitive tests done. So they have a file with their memory abilities, speed of recollection, etc. The baseline is there. And then if they have a concussion anytime in the future, their results are compared to that. So some of the research has shown that, a team approach of multidisciplinary specialists is important. A coordinated approach results in earlier diagnosis and management, and a coordinated approach of the different members, the rehab, the trainers, the doctors, the neuropsychologists, coordination of all of their input helps to get the players to return to play earlier. Or in the case of young people who are studying, helps a young person get back to school with the ability to learn, study, retain, and then progress in their learning journey. We'll go a little bit through this. The team physicians, they have the final medical authority, and obviously they have to follow the regulatory guidelines of either the rugby union or FIFA or the World Athletic organization. So in 2025 there are clear set guidelines on concussion guidance, and the minimum number of days that individuals have to be excluded from participating in any way, shape, or form. And there are clear guidelines on how long it's going to take for them to be allowed to return to their activity. So the initial medical evaluation is obviously to do the ABCs. Make sure that there are no life-threatening medical conditions, airway problems, breathing problems, circulatory problems. So once the ABCs are clear, obviously at the disability stage where you're checking for the GCS pupil reaction, an early decision has to be made as to whether there is a serious concern about concussion or something more serious. The physicians are also involved in the clearance, the medical clearance to return to play, or in the case of students and young people, return to school or return to learning. They're involved in the longer-term management of complications, identification and monitoring of persistent symptoms, and then referral to specialists. So again, a general team doctor may do the assessments and know when to refer to somebody who is a sports medicine consultant or specialist, or indeed a multidisciplinary specialist sports team at a tertiary specialist facility. Treatment planning is done by the group of all the trainers, the neuropsychologists. They all contribute to forming a treatment plan for any individual concussed patient. And in terms of the public, that is the same approach that should be if a young secondary school young lady or young boy gets injured, the community multidisciplinary team should also have a plan for them. Now, the trainers are the eyes and ears on the sidelines. That means their job is to look out for, they are looking at anything, any situation which might cause a physical injury. The current training is that it should include any situation that may potentially cause a concussion. So apart from looking out for physical injuries, they're looking out for incidents which may, even if not overtly. And so if it's not 100% clear, they may ask a few questions during breaks, during the game, or during halftime, or do a couple of assessments. And if there's any doubt between the trainers and the medical physician, they can make a decision to pull the player out. Continuous surveillance is important. The immediate assessment and documentation is very important at scene. And then after the injury, for organized teams, daily monitoring is very important. For members, just ordinary members of the public, the criteria and checklist for monitoring will probably have to be provided to the parents, guardians, teachers, so that they can keep an eye out. They know what to look out for over the next few days or weeks. Okay. I've mentioned about the neuropsychologists. They look at the cognitive function and recovery. So again, for organized sports and professional teams, they do baseline assessments which are on file, and then they compare after incidents that might lead to concussions. or that have been diagnosed as concussions. So you've got your baseline testing, post-injury assessment, and then these tests are interpreted, and the monitoring and documentation. A multidisciplinary team makes the decision of potential dates for return to play or return to learn, and then they meet again at a final. So it's like an MDT, multidisciplinary team meeting to agree the final return. Physiotherapists are involved with the rehabilitation. Now, neck and back injuries, because we're talking about concussion, the head is intricately connected with the neck. So a concussed player may very well have neck symptoms, and whiplash type injuries, and so physiotherapies are involved there. Though they're assessing the physical side of it, they have to be aware and work with the neuropsychologist and the sports medicine team to be aware of the concussion signs and also feedback. So every member of the team that interacts with the player is an important person, because knowing that the individual they're dealing with has a concussion, they can note certain things which suggest that that person is getting better or getting worse, and therefore they can feed that back to the coordinating physician of the team, or where it has to do with cognition, feed that information to the neuropsychologist, so that that diary of monitoring and documentation can continue. A lot of head injury or concussed patients have vestibular adverse effects. So it affects their balance, dizziness, blurred vision, etc. And there are physiotherapy specialists who specialize in dealing with the vestibular system, so that they help minimize the dizziness and balance issues through prescribed exercises and rehab protocols. There's exercise prescription, so specific exercises can be prescribed by physios. And then when somebody is returning to play, the physiotherapist can observe, monitor, and supervise the graduated return to normal activity. Right. So with regards to the future, regards to now and the future. So monitoring, we're all aware. These days, your average person can order or have a smartwatch, smartphone. Some of these smart devices can be monitoring your heart rate, pulse. There are mental health, wellness apps which monitor the mood of individuals. So if one of those apps on a schedule asks, "How are you feeling today?" It monitors the number of times that somebody says they are either a 3 out of 5, a 5 out of 10, or a 7 out of 10, or they're feeling very down. And that information can be downloaded and analyzed by the neuropsychologist. Things like the respiratory rate, the blood pressure, that might be helpful to the trainer. You've got on the physical side, you have video analysis of breaking down somebody's like a sprinter's stride length, and whether they are adequately recovering from an Achilles injury or a hamstring injury. So there's a lot of technology involved there. And in terms of preventing future injuries, because of the science that is available, the members of the sports medicine team that deal with these different aspects can look at the current measurements, and for the professionals, a lot of them actually have, when before the season starts, they have pre-season measurement of sprints, medium distance, long distance, and then so if somebody is coming off an injury, concussion or otherwise, the present data can be compared against their baseline data, so that whether they are returning to normal or static or worse. So this is a little table, a little stepwise listing of the injury surveillance. Consists of identifying high risk factors and looking at prevention. Load monitoring is measuring the training, making sure that you do not give somebody more than they can manage at any stage. Every time that they make 2 steps forward, if they look like they're struggling, you need to take them back and avoid overtraining. Biomechanical analysis includes a little bit of technology. They may do some video measurements, taking weight, other measurements. Recovery tracking includes monitoring of sleep, and then planning for return to play, and then prevention. Neck strengthening will obviously help minimize concussions due to whiplash type injuries. And there's a lot of research in various areas of concussion prevention and management. So applying evidence-based interventions also helps to return people earlier and minimize adverse effects. So now at the higher level, predictive analytics there's a lot of statistics in sports these days where teams are actually making trades for one player for another based on statistical analysis of how they play on rainy days versus wet days, or whether they need somebody to counter another team's left-handed pitcher in baseball, or so a lot of statistical analysis guides at the professional level. And then there's also risk profiling. So for certain positions on certain teams, that they have a higher likelihood of having possible head trauma or being involved in concussion type scenarios. So when they have the first couple of concussions, they need to be monitored very closely. And at some point, if they've had a few within weeks or months, they may have to take a longer break, or maybe sit out a whole season. So initial assessments, there are standardized protocols, including history taking, checking the symptom list against some of the concussion tools, cognitive screening, neurological balance assessments, neck or cervical examination. And all of these are put together as a baseline. And in the event of a concussion, they all get tested again to see if there's any changes for the better or worse. Sideline testing, you want to look at the signs, observable signs, check for immediate memory, concentration, the orientation, especially orientation within the space of the game. So if they've got no idea whether they're in the first half or second half, or third or first quarter for those types of games, that's significant. If they are unable to remember simple words after 5 minutes, that is the short-term memory affected, and delayed recall predicts a worse outcome. Again, the references for some of these tools, etc., are provided so that you can have a closer look. But generally, the SCAT-6 has about 22 items on a 0 to 6 scale, and you go through each and give a score. Like any scoring system, there's a legend as to what each score means. These results inform, but together with everything else, the clinical assessment, they help the team make a judgment as to whether a player should be judged as having concussion, and then what regime to follow, including when to return to when they're able to return to play, or in the case of students or learners, when they can return to learning. And actually for students, for people who are not students and just ordinary members of the public, when they can return to their normal activities, whatever they're doing, whether they are working, whether they are at home, includes whether they can return to maybe some hobbies that they have. So it's not just, but we're talking about sports here. So now I just took a little bit from the UK Royal College of Emergency Medicine guidance. All major bodies, healthcare bodies and sports bodies, take guidance from the international. So that consensus conference in 2022, provides guidance for it. And the principles are basically the same. This is, these are the same sort of figures which I gave earlier. I just took this because I'm in the UK. I wanted to give a UK spin on it. So in the emergency department, you want to rule out serious injury, which includes cervical spine injury and then traumatic brain injury. So CT scans, MRI scans will need to be considered. And then if everything serious is excluded and you're left with concussion, then that needs to be referred and followed up by the appropriate specialist. We don't normally use the SCAT6 or the sports concussion tools in hospital. GCS is useful and is the most that we will normally do. And the aim in the emergency department is to exclude life-threatening conditions. So for the most part, we want to make sure that having excluded life-threatening conditions, they are discharged and referred to a sports medicine team. Now, a lot of times when players are brought to the emergency department, for professional teams, it is expected that they have their own sports medicine team, including doctors. So we, the emergency team, just do the full assessment to exclude serious conditions and then discharge them into the care of the doctor of the professional team or organized amateur team. For members of the public, that follow-up may need to be by the general practitioner. And if the general practitioner detects things which they are not able to follow up or manage, they will need to refer to a sports medicine specialist. It's important to let individuals know that a second impact, or if somebody gets an injury during the vulnerable period, rarely that may be fatal, and in a lot of cases they have significant secondary concussions which delay their return to normal. You can have a look at the SCAT6 information later. So these I mentioned about baseline testing. I think I'm coming to the end of my time. Medical imaging. So scans are necessary when you suspect serious traumatic brain injury. For the most part, CT scans are indicated, but if there's significant signs, then an initial CT may be done because there are other musculoskeletal injuries involved, and then a specific MRI may also be done. And somebody with a history of significant brain injury in the past, it will probably have a default MRI in addition to or instead of a CT. So emergency imaging is suspect for GCS below 15, suspected skull fracture, prolonged loss of consciousness. CT scans can detect epidural hematomas, subarachnoids, contusions. MRIs are usually for persistent symptoms. But all these imaging, are sometimes they don't show anything at all. So then you have a case of functional brain injury. So you've got the first acute phase, 24 to 48 hours. And in the first 24 hours, especially, they shouldn't be alone. In the next 2 to 3 days, they should still be monitored closely. And then rest, no heavy exertion in the first few days. Athletes and families should know to seek emergency care. So if they don't have any symptoms at the time of the incident, and they go home or they go back to school and they're struggling, they need to seek emergency care. Non-steroidal should be avoided. Sedatives, alcohol, stimulants should be avoided. They may find that they need dim lighting or sunglasses, quiet environments, noise canceling headphones or earplugs may be useful. And then they may need short breaks. So rest and recovery are very important, especially in the first few days, couple of weeks. Social activity should be limited. Doing things, studying, writing long essays will be a stress on the brain. Obviously, physical activity is a stress, and then they need good sleep. Return to play and return to learn are step by step. So you have your initial rest period, aerobic, sport-specific exercise, non-contact training, then full contact, then a decision as to return to competition. Cognitive rehabilitation, the neuropsychologist will supervise that. Sorry, I'm just trying to keep within time. I do apologize, but rest assured, I hope you'll find the references that I send you very useful for your records. So things like how the ease of paying attention, their memory, ability to process information, and the executive function support. How are they able to solve problems, plan, organize? These are things that the neuropsychologists will manage. In terms of complications, post-concussion syndrome are some of the symptoms beyond a simple concussion, and they may be long-term. Risk factors for prolonged recovery, female, younger age, which is why there's a move to make sure that parents and coaches in little leagues and young people's sports are aware of concussion, because the long-term effects on younger people is worse than for adults. Loss of consciousness and injury, pre-existing migraines, those are risk factors. Persistent factors, neck injury contributes to persistent symptoms, mood disorders, so anxiety, depression, psychosocial stress factors contribute to persistent factors, persistent symptoms. Athletes suffer psychologically whenever they are off, they are unable to play. They feel they will lose their place. They feel they will not be able to get back to where they were. They feel they don't know how to do anything else. They have no other skills. So it can be quite anxiety provoking and depressive. So they need to be supported in terms of their emotional, psychological, social support. And I think I'm getting to the end here. All the stakeholders, the athletes, the family, the coaches, the teachers, the administrators, there should be good communication for all factors, because athletes at the higher level especially are very single-minded. They just go in, they just play their sport, and that's it. They expect other people to support and do everything. And so they're not very good when they are injured or ill or incapacitated. Okay. There are legal and ethical considerations. So there's a duty of care when sport activities are organized, that there should be a team at the sideline to, obviously to deal with serious injuries, but it's now recognized that concussions are just as important to look out for. So there's that duty of care of the team, the sports medicine professionals on a team, or in schools now, teachers who supervise PE are more and more supposed to, look out and recognize concussions early. Informed consent, so confidentiality, respecting autonomy. So autonomy means adults have the right to make their own decisions, even if your other average person would not do it. So as long as somebody has has adequate capacity, you cannot force them not to play any active sports, not to engage in any stressful situations. But professional teams, obviously, they own the team. They can say, well, it's our team. You might want to play, but we don't think you are fit to play. So we will not allow you to play in any games or matches for 2 weeks or a month or whatever. But that doesn't stop that player from going to the local gym and playing with a bunch of civilians or ordinary people at the local park. And that's a risk that they take if they do that. Okay. So there's protective prevention includes protective equipment, so things like helmets and mouth guards. Education is important to make sure, parents, coaches, athletes are all aware of concussion assessments. Sometimes rules are changed in different sports to prevent high tackles, heading, technique and training. So the fundamentals of any sport are important so that safe tackling, how to fall, and control during certain plays is important, especially to teach young people so that they avoid possible concussion later on. I will leave off this. This is a case, the study. Yeah, some of the latest technological things are blood-based biomarkers. There are wearable sensors. There's eye tracking technology that can track and pick up on involuntary, eye movements, which might be difficult for your average person to pick up. And then they've got non-invasive brain stimulation. There are some people who have been found genetically to be more prone to concussion or brain trauma than other people. So that's another level of, technology which can be used in the future. So some of the takeaways as I come to the end here, you need to look at assembling your team, having standardized protocols, which there's a handful of internationally accepted protocols, which most countries and the regulatory bodies follow. Prioritize education of athletes, coaches, parents, the community, value brain health, encourage symptom reporting, and then make sure that the medical components of these teams are independent and not pressurized into making decisions which will place athletes at risk. Baseline testing to compare later on is important, and everybody in the ecosystem should know how to recognize concussion. So just as I come to the end here, concussion is a clinical diagnosis. Immediate removal, if you suspect concussion, is important and mandatory, right? So when in doubt, sit them out. The 11 hours, recognize, remove them, reevaluate, rest them, refer, rehabilitate, recover, return to the sport, reconsider. Then last two are consider the residual effects and risk reduction. Multidisciplinary teams are essential. Active rehabilitation. So instead of complete rest, there should be active rehabilitation. Psychosocial approach, so a holistic view to managing the affected person, and then a graduated return to play, and for that matter, return to learn. So that is, in a nutshell, everything. And on that note, so as you can see, there's a whole list of relevant references for you, and I'm happy to take any questions. I do apologize for the slight overspill, but it's a big topic. Thank you.
Thank you very much, Dr. Bako, for that insightful presentation. We will take questions. If you have any question, you can either raise your hand and be unmuted, or can put it in the chat. I'll read it. Dr. Buckles, I think some people want the evaluation form reposted, the poll.
Oh, Maxwell, are we able to do that? Is Maxwell there? I'm gonna depend on Maxwell to do that. Maxwell is gonna.
Okay.
Is Maxwell on the call with us?
Yes, Maxwell is here.
Yeah.
Some people want the poll.
Yeah, Maxwell. There's a couple of the questions which were supposed to be selection selection from a list, but it seems to have been changed into free text, which was not the intention. Anyway, if you can launch the poll again.
Okay. Okay.
Whilst we're on this thing, let me see if I've got the. Okay, so all right, so the poll is on there. All right, so we've got what role do you serve? Okay, and then number 2. So have you recently been involved in managing a case of concussion in sports? Yes or no? Oh, it's only 2 people have. Okay, then the age of the patient, child or adult. The poll was just to give a general overview within the context of the presentation. So I just wanted to get an idea of the audience. So far, out of 34, the majority seem to be doctors. But it could have been that out of the 200 and something people on the call, there were a good number of nurses or psychologists. There may be one sports psychologist in the group, or there may be a couple of paramedics who are listening now. So there's only 3 people have responded to the age of the patient. Yeah, so I think I'm going to just end it here. It wasn't meant to be a scientific result. I mean, I could send it. I could convert it into a Google survey and send it out if you want, and then share the results.
Okay.
Is that an option?
Yeah, that's an option.
Okay. Now here's another thing. Before I close, I want to. Oh, how do I? Oh, I don't want to. Yeah. Can you see my screen still?
Yes, I can.
Okay. So what I've got here is right. So I've created a little presentation based on based on applying the 11 hours. So I shall share that with you. And these are 5 scenarios where you will have a situation described, and then you'll go through some questions about what should happen next, and then it will identify the actions to be taken. So that will be just for your personal exercise. If we had a 2-hour session or 3-hour workshop, we could have done that, but I'll share that with you also. Is that okay?
Yes, that is okay.
Okay, right. So apologies once again for the extent. Sometimes I get carried away, but I thought since sports medicine is evolving, we should try and supply the those who are interested
Arsenal.
with the little that I could find on the subject.
Yes, we really appreciate it. Thank you very much,
You're
Dr.
most welcome.
Bako.
Yeah.
I will be in touch.
Yep.
You could send the presentations to me and I could send them out. Okay. So there are a couple of groups, but I do not have everyone's email. I will share my number in the chat box, so you can reach me on WhatsApp if that's okay with you.
Yeah. Yes.
So that's my number. You can hit me on WhatsApp. I can forward the presentations to you. All right. Thank you all for joining us today.
Sorry, Gamal, could I have could I have at least one or two just give their feedback to Dr. Annan and myself as to whether it was useful or
Yes,
what
so
could be
there's
done?
a
What could
couple
be
of
done
people in
differently?
the chat. They've put it in the chat.
Oh, they put something in the chat.
Yeah,
Well,
excellent presentations, very good
yeah,
presentations. Thank
yeah,
you.
yeah.
Thank you.
Oh, thank you for that. So, I've really, I would appreciate your feedback when you get the presentations, but hopefully, one or more of you will conduct some serious research in the next couple of years, so that we can cite your research for future presentations.
Hopefully, fingers crossed.
Yes, yes,
Dr. Conrad, some people may want to get in touch with you. Are you okay with me sharing your?
yes, yes, yes. No problem.
All right.
Yeah.
Okay. Thank you very much.
Okay. Okay. All right. So, if that's all, then we'll sign off. I wish you all the best for the rest of the day, and thank you for having me.
Thank you for taking the time out to do this. We
Okay.
really appreciate it.
Okay then. Bye-bye.
Bye. All right. Ladies and gentlemen, this brings us to the end of the Sports Medicine Symposium. There was an in-person session in the morning, where the Minister of Sports and Recreation, the lead trainer for the Sports Exercise and Rehab Medicine Training Program, Dr. Abnatan, gave us presentations. There was a panel discussion which focused on the gaps we have in sports medicine. Thank you all for joining us for this virtual session. Like I said, I've shared my number, so anyone who needs the slides can reach me on WhatsApp. My name is Gameli, and we want to thank you all for joining the Ghana College of Physicians and Surgeons, the SEM, and then SOFPOG. We want to thank SOFPOG, Society of Family Physicians of Ghana. Thank you all, and I will see you. Dr. Baba, do you want to say something before we go? No. All right. Goodbye. Have a good evening.
He's not on the call.
Yeah, I just realized. All right, goodbye and have a good evening.